Our next presenter is going to be Dr. Qais Alemi. He is an associate professor of research methods at Loma Linda University School of Behavioral Health. He is a global health researcher with a focus on understanding the mental health and psychosocial needs of populations affected by political violence, and is one of the most published Afghans in the field of mental health. We are very honored to have him join us today virtually to present on the causes and etiology of child trauma in Afghan refugee children.
Okay, well, I just wanted to start by saying thank you to Dr. Sadiq for coordinating this workshop. I'm very honored to be a part of this effort. And I also want to thank Dr. Koga for taking part in facilitating this as well and inviting me to be a part of this. Totally honored. I also want to thank the attendees as well, just to express my appreciation for your service to the Afghan people, people whose issues are very complex, as you guys, most of you know, and especially when it comes to children who, what I'm finding through my research and through my search of the literature on Google Scholar and PubMed is that, children are often overlooked when it comes to mental health and psychosocial support of the Afghan people specifically, right? So a lot of studies have really focused on the mental health and psychosocial needs of adult refugees, which makes sense because the health of parents or first generation or second generation or older refugees, I should say, it is a real determinant of how well their children actually do upon resettlement in terms of their adjustment and whatnot. So my research has really focused on the mental health of adult refugees, and but through my interactions and with community members and doing surveys in places like Turkey, I've come across a lot of children and children who are unaccompanied, which who are a real high-risk group for PTSD. And what I plan to do today is, go over a few studies, and I promise I won't bore you with too much data, go over a few studies that really sort of expose the challenges that children face and the vulnerability that, that they possess, essentially. So we'll go on to the next slide here. So the objectives of my talk today are to broaden understanding of the severity or the magnitude of trauma among Afghan children in country, within Afghanistan, because understanding what goes on in Afghanistan can really give us that context and perspective as to what we can expect in a clinical setting in working with children, right? So I don't think much of the stuff I present is going to be surprising to anyone. You don't have to look too far. You can just turn on your TV and really see what the Afghan people go through, especially children. And among those who have become refugees, so I'll highlight the severity of PTSD among children who have become refugees, and there's very limited knowledge in this area. So we'll do what we can to unpack the etiology of trauma as well. What causes trauma in Afghan children? Again, where does trauma stem from? And I want to also talk about the factors that prolong its symptoms and consequences. And you'll see that a number of social factors really exacerbate PTSD symptoms. So there's war experiences, right? But then social factors are, essentially things that, help explain why PTSD symptoms stick around for so long, even years after resettlement, right? I also want to identify a few psychological interventions that show promise in terms of improving the mental health of traumatized Afghan children. Again, the knowledge base in this area is very limited, and I know this afternoon we're going to have a few speakers talk about psychological interventions, but I'm just going to touch on them here. Interventions that are specific to refugee children. So I'm going to go on to the next slide here. So in terms of context and background, so it's no surprise that the sheer numbers of refugees and displaced individuals has grown in recent years due to more conflicts, more wars, economic downturn, political instability, political violence, so on and so forth. But this triple trauma paradigm, which I believe most of you in the room are familiar with, essentially puts it into context, right? The stressors that refugees face into context, right? There's the pre-migration traumas, which are defined by war experiences and exacerbated by ongoing daily stressors, especially in the case of the Afghan people, right? So it's poverty and a number of daily social stressors that really aggravate traumatic symptoms for the Afghan people. It's not just war experiences. And then there's also the trauma of flight as well. And in this process, people lose loved ones, they get detained. They're subjected to sexual violence, especially young people who are unaccompanied refugee minors who often seek settlement in Western Europe, right? And this is something that I witnessed myself in talking with several young people in Turkey, who were making their way through Turkey into Western Europe at the time, back in 2015. So there's a trauma of flight, and then there's a host country trauma, and this type of trauma, really relates to loss, right? So refugees deal with a great deal of loss, as you guys know, and it's loss of country, it's loss of land, it's loss of identity, belonging, so on and so forth. But trauma can be prolonged, despite they have the safety of being in the United States, for example, but trauma can be prolonged because, there's also discriminatory stress, right, and cultural adjustment challenges that people face, especially young people, right? And so with 40 years of war in Afghanistan, you can expect that, there's going to be intergenerational trauma, right? And this is the type of, trauma essentially that's passed from one generation to another. So if I think about my parents, for example, who lived in Afghanistan when the Soviets invaded, that's one generation that was affected by, war atrocities, a population or a subpopulation that was traumatized. And then there's my age group, people who are in their 40s, children of these individuals who lived in Afghanistan when the Soviets invaded. And then there's my children as well. If I were to live in Afghanistan, my children would, sort of carry on that trauma as well and would pass it on to their children. So it's about, safe to say that 3 generations of Afghans have been traumatized, and it seems like a cycle that's never going to end so long as there's economic deprivation and, so long as the economy stays frozen and the situation or the conditions don't improve. It's just going to continue. I don't mean to sound so pessimistic, but that's just the reality of the situation. So again, intergenerational trauma experienced in one generation affects the health and well-being of future generations, right? And there's no real studies that focus on the Afghan people specifically when it comes to intergenerational trauma, but a recent systematic review, which is I was going to say it's cited at the bottom of this slide here. That's probably the next slide actually. But a systematic review finds that when comparing children of refugees or children of traumatized refugees to children of immigrants do much better post-resettlement in terms of their pro-social behaviors, in terms of their family relations, in terms of decreased levels of delinquency, and so on and so forth. A number of outcomes are much better for kids who don't have parents who are traumatized, if that makes sense. Okay, so again, children of refugees who have refugee parents who are traumatized do far worse than children of immigrants who don't experience traumatic events. So PTSD, though, is common, as you guys know, in the aftermath of war and political violence, and 1/3 of children exposed to traumatic war experiences meet, diagnostic criteria for PTSD, essentially, right? But again, I'm going to emphasize that it's not just war-related experiences that contribute to PTSD. It's an accumulation of stressors that operate at different dimensions of one's, social ecology, if you will, at the micro level, at the meso level and at the macro level, essentially, right? So it's an interaction of the direct consequences of war and, factors that, or conditions that are prevalent at, different levels of one's social ecology, such as, extreme poverty, lack of resources for health provisioning, breakdown of school systems, increased rates of family and community violence. So it's a number of factors that interact together that, exacerbate trauma and prolong it as well. So what we find, though, is that, trauma actually, and psychopathology that comes with it, and the negative coping strategies in parents are catalysts for domestic violence and child maltreatment. And this is very important because in Afghanistan, what the data shows is that family conflicts or family violence within families is a direct consequence of decades of war and conflict that has impaired parents essentially and has destroyed families essentially, right? So, and what we see is that children who grow up in the midst of war are at greater risk of developing challenging behavioral problems that are associated with their traumatization, such as angry outbursts and irritability. And this makes it harder for parents to manage these children, so they resort to coercive parenting strategies, right? And that means, hitting their children and being violent towards their children, essentially, right? So families, though, while they can serve as a risk factor, family is the most important institution in Afghan culture, and through care and warmth, they can serve as a source of strength and resiliency in the face of war trauma and the accumulation of different stressors, right? So, and you'll see later on in the slide set here that interventions that focus on improving family relations seem to be very effective in reducing traumatic symptoms in children. So that's a slide that is coming up soon here. So if you look at data from Afghanistan, the study conducted by Katani, and it's a smaller sample of young people from different districts in Afghanistan, but you can see the types of traumatic events that they've been exposed to. There's experiencing violence at home, and you see that boys experience violence at home more than girls, right? In some cases, the different experiences are significantly different, right? But anyways, experiencing violence at home seems to be much higher, about 20-some-odd% according to the chart on the left, for boys versus girls who experience it about 13% or so. But then there's war experiences, and then a bunch of other war-related traumas that are listed here in this chart. But you can see that violence at home is experienced much more than war experience, which is surprising, right? And then let's see here on the right side of the scale, this chart really breaks down the types of family violence that children report, such as physical violence, being slapped, or verbal abuse, being shouted at, right? Hit with an object, punched and kicked, and so on and so forth, right? You can see all the different types of violence that takes place inside the home versus the traumatic events that, take place outside the home, in some cases inside the home as well. So it's different, the experience is different by gender, and boys seem to be, at higher risk. So the severity of trauma, according to this slide over here, has gotten far worse after the fall of the Afghan government, right? So this data over here points to a deterioration of psychosocial well-being in children. And again, I promise I wouldn't bore you with so much statistics here, but if you just look at the PTSD prevalence according to the Qais scale, we see that this total sample of boys and girls, 50% meet diagnostic criteria for PTSD diagnosis, according to this right here, but it's much higher, in this sample at least, seems to be much higher in girls versus boys. And this is a recent study after the fall of Kabul. It took place after the fall of Kabul, I think. And yeah, it was published in November 2021. So, yeah. So, as opposed to the previous study showing that boys are at higher risk, this study shows that girls seem to be at higher risk. But all in all, 50%, over 50% meet diagnostic criteria for PTSD diagnosis. And then there's also other outcomes due to depression and anxiety, but our focus today is PTSD, that right there. So those studies right there were conducted in Afghanistan, and there's not much that's been done with children in Afghanistan, but I think those two studies that I presented, hit home, the message in that Afghan children are highly traumatized, and they suffer greatly, right? And then this slide and the one that follows really focuses on refugee children, and the studies that have been conducted with refugee children have been conducted in places like the United Kingdom, and I believe this one was done in Sweden, and they're usually done with unaccompanied refugee minors or unaccompanied asylum-seeking minors, right? So we see here in comparing Syrian, Iraqi, and Afghan refugees that unaccompanied Afghan minors were at greatest risk, had the highest odds, I should say, of PTSD. And you can see I'm hovering my mouse over the 60% over here. I hope you guys can see that, but it's at the far right under the Afghanistan column. So the unaccompanied Afghan minors are at greatest risk of PTSD. And the accompanied ones are also at higher risk of PTSD than the Iraqi children and the Syrians as well in this sample. So Afghans, all in all, again, are at highest risk of PTSD according to this very sizable sample, 374 people seeking asylum in, I believe, Sweden. Yes, and the reference is down at the bottom here. Yeah, a very high-risk group. And this one over here, this slide over here shows that unaccompanied children in the United Kingdom, about a third of them also met criteria for PTSD diagnosis according to the RATS scale. And you can see here the types of different traumatic experiences that they report. Loss of a loved one is 80% in this sample. And the list follows, as you can see here. Now, I don't know how much or to what extent the audience here, service providers, deal with unaccompanied minors, but there are some cases that I come across down here in Southern California. My boss, for instance, she's a professional social worker, so she'll email me, cases of individuals, children who have no parents that are in group homes, essentially. They've recently arrived, but it's very rare that we come across unaccompanied refugee children down here, at least in Southern California. It might be different for you all in Northern California there. Okay. So, in terms of promising psychological interventions for Afghan children, so there's culturally adapted cognitive behavioral therapies that show promise. And there's a couple here that relate to writing for recovery or written exposure therapy, right? And this essentially involves, writing about a specific traumatic event in detail, paying particular attention to, one's thoughts and feelings that occur at the time of the event. So anyways, it's much deeper than the way I'm explaining it, but written exposure therapy is a brief intervention that shows promise in reducing PTSD symptoms. And this first study here, the first bullet, was conducted with adolescents or bereaved adolescents in Iran, and it demonstrated good efficacy in 3 months follow-up as well. So 3 months after the intervention was over, PTSD symptoms remained low. and then for Hazara war-exposed adolescents as well. And this second study here was conducted in Afghanistan. So, with Hazara children exposed to a terror event. And then this last study here, bereaved Afghan adolescents in Iran, which two actually were conducted in Iran. This one combined memory specificity training and modified brain exposure therapy. And they found that it reduced depression and PTSD symptoms, and the effects remained 3 months at 3-month follow-up. So they, all these studies use pretty sophisticated designs, so they're very credible in the sense that, they're randomized controlled trials. They had this experimental group of adolescents in this WET, brain exposure therapy intervention, and they compared to a control. So you can rest assured that, these interventions, are efficacious and they're worthy of considering. And the references are down here in case you want to look further into that and maybe adopt them or adapt them for your population. And then there's also life skills training, and there's a program called Strong Families. The key premise for this program is that change in parenting skills is a key mechanism for reducing and preventing future child behavioral and emotional problems. So what it does, it's designed to improve parenting skills as well as child well-being and family mental health. And it's, again, promising. We found clinically significant improvements in child mental health measures, along with improving parenting practices like reducing harshness and communication between caregivers and children. And they tested Strong Family in Afghanistan, in Iran, and in Serbia, and the references are here for you guys to look at further. And this is another promising intervention that can improve mental health of Afghan children. Other promising interventions include narrative exposure therapy, eye movement desensitization and reprocessing, and then there's also child-centered play therapy. Now, these have not been tested with traumatized Afghan youth. These are interventions that have been tested with refugees in general, but I suppose, I guess to some extent they can be adapted and applied to Afghan children, or maybe Afghan adults, families. So they're worthy of considering as well. I know, again, this afternoon you guys are going to get a talk on promising interventions, but just wanted to touch on a few here. So, in summary, Afghan children are a highly vulnerable, traumatized, and neglected population. Although the research literature is limited, we see that they have many different experiences when it comes to war-related traumas, right? And family violence as well. So PTSD is not the only driver of war-related traumas. Or I should say PTSD is not only driven by war-related traumas, but it's an accumulation of stressors that span various social ecological dimensions, right? Ranging from, the family system all the way to the society level. So factors operating at these different levels of one's social world, really contribute to PTSD symptoms, right? Or PTSD diagnoses. Intergenerational effects of trauma are understudied among Afghans, and a likely compelling reason for PTSD and other psychopathology in Afghan children, perpetuating a cycle of violence, right? So, intergenerational effects of trauma. Interventions targeting PTSD in children are limited. However, as I just showed you guys, preliminary research finds that, improving family dynamics and parent-child relationships offer promise of improving mental health. And that's all I have. Thanks so much.
Thanks so much, sir. Assalamu alaikum. I am Mumtaz Muman from San Diego. My question is that what type of mechanism has been adopted in order to control pressures on unaccompanied minors, since they're in bases or shelters? And have you ever taken any measures in order to control PTSD or any other pressures on these minors or not?
Thank you for your question. You know, the extent to which we receive minors out here in the Empire, which consists of San Bernardino and Riverside counties, is very low. And, you know, but I hear of several cases of, you know, settlement agencies or social service agencies dealing with unaccompanied minors. And I would think that, you know, the way they intervene is somewhat reactive because the cases are so rare. And so no, to answer your question, no, I haven't personally taken any measures to address their needs. And, you know, the number of minors coming through again are very low. So, then again, I'm not a service provider. I'm a researcher at a, you know, health, you know, at a local university here in Southern California. So, yeah, so I'm not aware of any measures that are specifically taken for minors either. So.
Thank you, Dr. Qais. We really appreciate your time, and we thank you for your participation and supporting our workshop. We really appreciate it. Thank you so much.
Thank you.